Hello, Nicolette here. So today we're going to be covering hypertension. So when we think about hypertension, we are trying to understand how it is the blood is flowing in and about the circulatory system, right? From the heart to the lungs, to the brain, to the kidneys, down to the extremities. And when we can understand what is happening and how um, the the system is working to get the blood flowing, we can understand why hypertension is so detrimental. Okay, so the idea behind hypertension is it is the amount of resistance of blood pumping through the arteries. So what that means is when you think about the flow of blood, how the blood is pushing against the blood vessel, right? Um, if anything is wrong with those blood vessels, it's going to affect the pressure, right? We're going to see later that if the vessels are narrow, then the push is stronger. If the blood vessels are longer, then the push is going to be diminished because of the distance that it has to go. If the fluid, the blood itself, is thicker, the push is stronger, right? So all of these different things can affect blood pressure. But let's think about what it is, what's happening. So we have what we call oncotic pressure. Oncotic pressure is found in the proteins. So we have proteins, which are like sponges, and they're pulling the fluid, right? They're pulling out the fluid. And then you have hydrostatic pressure, which is pushing at the fluid. And the dynamic between the two, the push and the pull, keeps the blood flowing in the blood vessel. Now, when hypertension happens, it is when the tension is too high. And we measure that, right? We measure that by saying the systolic blood pressure is higher than 130 and the diastolic blood pressure is greater than 80. So when we think about systolic, what are we thinking about? We're thinking about the number on top, right? So we have a number on top, we have a dash, we have a number on the bottom. Systolic is the number on top. That is the number that tells us how the contraction is happening, how the pump is going, right? And so the systolic number is the stimulation, it's the contraction of the heart. The diastolic number is the number on the bottom. That is when the heart is relaxing, right? It's trying to dilate, it's trying to open up to allow blood to accumulate before it pumps it, before it contracts, right? Now, how do we know a person has hypertension? We would need to have two readings, at least two readings consecutively that are in that high range, 130 to 100 over 80, right? In order for us to say that the person has hypertension. So that's 130 to 139 or 80 to 89. So that would be called stage one. So anyone who has a blood pressure of 130 to 139 over 80 to 89 has stage one hypertension. Anyone with a blood pressure of 140 and higher, over 90 and higher is stage two, right? So remember that we have um, the diastolic and the diastolic is in the bottom, the systolic is on the top, and the different numbers indicate to us what is happening, right? So now, when we think about the different kinds of hypertension, there are two kinds. There is what we call primary and secondary, right? And well, before we get into that, let's talk about some of the problems that hypertension can cause. Hypertension can cause problems with our heart. It can cause problems with our eyes. It can cause problems with our kidney. It can cause problems with our brain. Those are the four places that hypertension can cause the most problems. Okay. Um, the other big problem with Hypertension is that it is a silent killer. You don't know when these things are being affected. It's just, lo and behold, years later, after some time, you develop issues, right? And so, one of the important things that we tell people with hypertension is that they have to continually be monitoring their heart, their eyes, their kidney in order to be able to identify when they develop any issues, right? Um, Now, when we think about hypertension, when we think about blood pressure, there's a concept of MAP, mean arterial pressure, that we have to consider. We have to think about, right? And this is why the damage may occur. We have to think about how much pressure, how much fluid does it take to allow the whole body to be perfused, to allow the system to work properly for the heart, the kidneys, the lungs, all of the organs to receive the fluid that they need in order to thrive. So that is a MAP, the mean arterial pressure. That is the number that indicates that the system is doing its job. So the average arterial pressure throughout one cardiac cycle, so that's systole and diastole, one cardiac cycle, uh, that is the definition of mean arterial pressure. Again, it is the average arterial pressure throughout one cardiac cycle, that's systole and diastole. So there's an equation. It's 2 times the diastolic blood pressure plus the systolic blood pressure over 3, right? And the clinical signification or significance, I should say, is that it is essential to have the person perfused, right? If we have good MAP, we know that the person's organs are being perfused. What is good MAP? So good MAP is between 70 to 100. So that is within normal range. Anytime we have 70 to 100, we know the body is being perfused properly. There's enough blood circulating. There's enough cardiac output. There's enough blood perfusing through the cardiac cycle, systole and diastole, to allow the organs to function well. So anything less than 60, we have a problem. The brains are not getting enough. The heart's not getting enough. And eventually, in order to keep the brain and the heart alive, we're going to start shunting blood from other areas like the stomach, like the fingers and toes, in order to keep the heart and brain alive. Now, in hypertension, it's not less, it's more. So in hypertension, the number is above 100. So that is too high. This person is experiencing a high arterial pressure, right? And this high arterial pressure is going to lead to damage, right? If you have something that's causing friction, that's causing pressure on an area too much, eventually it is going to cause some damage, right? And it might even cause some blood clots because of how it's flowing throughout the body, right? Another issue that we have when we think about blood, I mentioned it before, is what can affect the blood pressure, right? We mentioned the viscosity, how thick it is. When you think of drinking a slushy through a straw, the thicker the slushy, the more pressure you must apply in sucking it in order for you to receive the drink, right? As a matter of fact, depending on how thick it is, you can't even use a straw. You need to use a spoon. That's the same concept with blood pressure. If the blood is thicker, it's going to cause more pressure. It's going to have more blood pressure, right? Higher blood pressure. The other issue is with the length of the blood vessels. The further away the blood vessel is, the more reduced we're going to have the pressure because it has to go further, right? It should be the higher the blood pressure because it has to go further. Forgive me. So because we know that it's going further, so we're going to need more pressure to get it to the extremity, right? So for example, when we think about the distance between the heart and the lungs and the distance between the heart and the body, the pressure that is sending blood to the body is higher because it knows it has to go further. Whereas the pressure that's being applied to the lungs to get the blood from the heart to the lungs is less pressure because it has to go a shorter distance. The other issue is vessel diameter, right? So with vessel diameter, we're looking at how thick, how wide, right, is the blood vessels. And the wider the blood vessel, the less the pressure. So the lower the blood pressure, the smaller the diameter, right, the higher the pressure. So if we have this much space as the fluid is going through, it doesn't have to hit the wall as much because there's a lot of space, right? But if the space is close together, it's shorter, then we have to allow pressure in order for the blood to pass through, right? So blood viscosity, vessel length, and vessel diameter affect blood pressure, right? So the blood pressure will increase if we have high viscosity. It will decrease if we have low viscosity. It will increase if we have a longer length. It will decrease if we have a shorter length. It will increase if we have a greater diameter. It will decrease if we have a shorter diameter. So the next thing we're going to see is now the factors that affect arterial pressure. So the blood viscosity, the vessel length, and the vessel diameter, they all affected the systemic vascular resistance, right? So this is to overcome and push the blood through. This is what the systemic vascular resistance is, the peripheral vascular resistance. Now we're going to talk about the what affects the arterial pressure itself. So the first thing that affects the arterial pressure is the SNS, right? So we have the sympathetic nervous system, and this is where we have certain stimuli that allow the body to know, okay, blood pressure is high, we need to do this, right? So for example, we have receptors that are in the arch of the heart, right, that feel pressure of the fluid that's going through it, and it sends signals to the brain. It says, hey, I have a lot of water here. Maybe you should do something for us to reduce it. And then they'll send signal to the pituitary, that'll send signal to the kidney that will either release fluid or hold fluid back. In this case, if it's too much, it will release fluid, you will urinate a lot more. However, if it feels like it doesn't have enough pressure, if the baroreceptors of the heart feel like they do not have enough fluid, it will send a similar signal to the brain, but this time it will be telling it you need to retain your fluid. So antidiuretic hormones will be released. So antidiuretic, do not pee. The body will hold the urine and it will increase the blood volume, which will then increase the blood pressure because more fluid, more pressure. Right? So that's how the sympathetic nervous system works. This also goes hand in hand with MAP, right? So MAP decreases the heart rate. When the MAP decreases, the heart rate increases. And when cardiac output increases, that causes vasoconstriction, right? And MAP, when it increases, then the heart rate decreases. And so then the cardiac output decreases, it causes vasodilation, right? So another part that affects the arterial pressure is the RAS system, the renin angiotensin aldosterone system. So this is when we have, again, a signal that is going to be sent to our kidney, which is going to tell the body whether it needs to hold aldosterone, which is a salt, or release aldosterone, which is a salt, right? And we know the concept of water follows salt. So when the brain realizes it has too little water, for example, it says, hey, let me hold my salt. Water follows salt. It will accumulate the salt, right? And therefore, it will now accumulate the water because the water is going to follow the salt. And when it does that, volume increases, blood pressure increases. The opposite will happen if the body feels like it needs to release the water. It will get rid of the aldosterone. And so the water is going to follow the aldosterone and it will release that, right? But how does it do it too? We have the renin-angiotensin, so we have vasoreceptors where the renin are vasopressors, right? Renin also causes vasoconstriction, and we have vasoconstriction. Once we have vasoconstriction, now we're going to have increased blood pressure because the space is smaller. It has to push against it, right? And if we have increase in diameter because of this angiotensin, right? Angiotensin 1 convert or renin is released and it converts to angiotensin 1, and angiotensin 1 converts to angiotensin 2. Angiotensin 2 is a vasoconstrictor, and that is what either is going to constrict or not constrict, right? So that's the RAS system. It affects the salts and it affects the diameter, right? We also have hormones and peptides like ANP, BPN, and all of these are hormones that tells the heart what to do. So we have like ANP, which is the arterial natriuretic peptide. It's secreted in the aorta and it promotes dilation, right? And we also have BNP, which is the brain natriuretic peptide, and it is secreted in the ventricles. So all of these different, we also have another one, ADH, right? Antidiuretic hormone, which we already mentioned, where it promotes a vasoconstriction and retention of water or release of water. So these are the hormones that could affect blood pressure. Again, we have the factors that affect arterial pressure are the sympathetic nervous system, the RAS system, and hormones and peptides. So we mentioned earlier that there were a few different kinds of hypertension. We had primary, we had secondary. So primary, they don't know what causes it, right? It's called essential hypertension. But secondary, it's exactly what it's saying. It is second to something else. So something else happened that is now causing the person to have hypertension. So if you can get rid of that something, the hypertension will go away. So what could be secondary causes? It can be Cushing's, it can be pregnancy, it could be renal failure, diabetes, hypo or hyperthyroidism. So if you resolve the kidney failure, maybe give them or put them on dialysis. If you resolve the Cushing's syndrome, remove the adrenal gland. If you give them insulin for diabetes, if you remove the hyperthyroid, these problems of hypertension will go away, right? Now, when we have hypertension, like I said, we have our numbers that tells us how bad it can get, and a complication is hypertensive crisis. Hypertensive crisis is when we start seeing damage, right? It's once the blood pressure is so high, like 180, over 120, right? And we have increased blood pressure that is so high that it's causing damage to organs, the eyes, the kidney, a heart attack, or like brain, a stroke, right? Ischemic of the brain. Some damage is happening right now. And so because it's happening right now and the blood pressure is high, we call it a hypertensive crisis. Okay, so now let's talk about some clinical manifestations. We already mentioned that it's a silent killer. So you won't be able to see it all the time. When you have a person has hypertension, they don't even know until they go to the hospital to check it. However, once it starts to manifest, once the damages of the organs start to occur, we're going to see it. We already mentioned which organs. Do you remember? The eyes, the heart, the kidney, and the brain. So those are the four places that you will start noticing issues. So you'll have blurred vision, you have dizziness, you have a headache at the back of your head. Like those are usually the issues. Sometimes you'll have nosebleeds as well, but that is when you are starting to have an issue with hypertension, and you're going to start seeing the clinical manifestations, but it doesn't always happen, right? So let's talk about some risk factors. What are some modifiable risk factors? And what are some non-modifiable? What does modifiable mean? Modifiable means that we can change this. This is a problem that occurs that we have a control over. And if we stop doing something or start doing something, we can change the outcome. So there are things we can do that can allow us to improve hypertension. As a matter of fact, hypertension and diabetes are the two diseases that I know of that we can cure through lifestyle changes. So that's a modifiable factor, right? So what are they? Sodium intake. So when you take into a salt, water follows salt, you increase the fluids, and that can cause hypertension. So reducing sodium will help us with hypertension, right? Obesity. So what happens in obesity is that it causes some effect on the kidney, like the fat around the kidney causes it to be activated and release the renin and angiotensin aldosterone system, which causes it to be out of whack, right? And the sympathetic nervous system gets activated, and that can cause hypertension. And so, what do we do about obesity? We lose weight. We exercise. Another one is alcoholism, right? Excess alcohol consumption can cause hypertension. And the reason why it's doing that is because the more alcohol you drink, right, you can develop hypertension because it's causing a vasoconstrictive effect, right? It's causing the muscles of the blood vessels to vasoconstrict, right, to get narrower. And so when it causes it to be narrower, we have hypertension. So if you stop drinking, you will not have hypertension if that is the cause of it. The next one is stress, right? So stress, the reason behind why stress causes hypertension is because stress elicits the sympathetic nervous system responses, the fight or flight, right? The cardiac output increases, the heart rate increases. And so because of that, blood pressure increases. Okay. And so when a person is in high stress, their blood pressure is going to go high. How do we get rid of stress? We can remove whatever the stressor might be and get some help. Okay. So those are the modifiable factors, but we also have non-modifiable factors. Non-modifiable factors are things I can't do anything about. I don't have control over it. And examples are genetics. I can't control what genes I was given by my mother or from my father, right? And so some genes, like the blood pressure issues, like it's passed on, issues with your kidney, issues with what else? Salt intake, how the body receives and processes salt and fluids. That is a genetic thing. Whether or a vasoconstriction, how the body reacts to that, right? With aldosterone, those are genetic issues that can cause hypertension. And then there's age. With age, everything kind of diminishes, everything doesn't work properly, the arteries get stiffer, and so because the arteries are getting stiffer, that can increase blood pressure. Okay. Family history is kind of the same idea as the genes, right? You can't help with genes you're given, same way you can't help which family you're born into, right? And so if a person had a stroke in your family, had cancer in your family, had heart disease in your family, it's the same idea. Hypertension runs in families, so you just might have that gene. Okay. In race, African Americans are the race that has the most prevalence of hypertension. And the notion behind the amount of stress that African Americans are put through because of society kind of is relevant to this fact in that, they always say how, they're scared to go out because of police brutality or being pulled over or having to do more than most. There's a lot of stress that goes with being a Black person, especially males. And as a matter of fact, Black men are the ones that have more instances of hypertension. Okay. So now that we know a person has hypertension, they uh they've gone to the physician, they've been in the clinic, they've been in the hospital, and 2 times we've taken their blood pressure and we've noticed that it is higher than 120 over 80, right? That tells us there's a problem. What are some of the symptoms we said we might be able to see if there's already damage in the body? We said blurred vision, headache, chest pain. We could have bloody nose, dizziness. We could even have ringing in the ears, right? So now that we are aware of this, and what are some things that we can um, do for them? Because a lot of times people don't come if they don't have symptoms. They have these symptoms, they come, and we find out it's hypertension. What are some things that we can do for this patient? We can educate them to explain what hypertension is, what they can do in order to get rid of it if some of the factors that is causing it are modifiable. If they're obese, if they're drinking, right? If they're taking a lot of salt with their diet, we can educate them. What else can we do? We can make sure they monitor their blood pressure, right? We know that when they monitor their blood pressure in the hospital, is not as efficient or accurate as if they monitor it at home. So we're going to teach them how to do that because we have what's called white coat blood pressure or hypertension, which is anytime they go to the hospital and they see a doctor, their tension goes up, but their blood pressure goes up. And so when they're at home, if we show them how to do it, they can calculate better and we can have better or accurate numbers, right? We can take their history and find out, who their family were, what diseases they had, or if anyone died, did they die of any kind of issues, glaucoma, hypertension, heart disease, diabetes, that kind of thing. We know hypertension runs in the family, so we would like a history. What else? Um, Sensory deficits. We want to know, are they able to feel their fingers, their toes? Because we know after some time, the periphery, right? If the heart and the lungs and the organs are not getting oxygen the way that they're supposed to, they're going to start shunting from the fingers and toes. And eventually, it's going to start causing some damages. And the fingers and toes are not going to feel the same way. They're not going to have sensation the way that they had before. Okay, we're going to tell them to report their hypertension, right? And not ignore it. No, make sure they know the numbers, right? Have them teach us back, like, what is the number? What is the level supposed to be? Tell them to take their medication. That's highly important. We haven't spoken about which medications yet, but they need to be adherent to medication. A lot of people, because they don't feel sick, they don't want to take medication. But we know that if they don't adhere to the medication, the blood vessels only deteriorate and they only get worse, and the damage, if it hadn't started, will begin. Okay, so we definitely want to make sure that we're doing these interventions. Now let's talk about some medications, right? And some more treatment. So let's talk about intervention for life, style, like habits. What would we tell them to do? We would tell them to exercise, right? We would tell them to lose weight. We may tell them if they're drinking to stop drinking, if they're smoking to stop smoking, if they're stressed to remove their stress. Okay. But what are some medications? Some medications are thiazides. Thiazides are diuretics, right? We have thiazides and we have loop diuretics as well. Loop diuretics can reduce the fluid even faster, so we have to be careful with those. But thiazides remove the excess water and sodium from the kidney. So the one thing we have to watch out for is we're not supposed to give um, these patients lithium, and we need to make sure they have enough potassium because it tends to deplete their potassium as well. Another medication is calcium channel blockers. So calcium channel blockers lower heart rate and the workload of the heart. But we have to watch that they don't become bradycardic. And we have to monitor those who have heart failure or heart blocks. Another medication is ACE inhibitors. So ACE inhibitors are really good because they stop remodeling. And what remodeling is like, when you have inflammation and you have damage to any skin area, you have scarring because it's healing. Well, whenever you have a scar, there's a change in how that place or area functions. The thicker the scar, the less the function. So remodeling is like scarring. So ACE inhibitors reduces the amount of scarring that happens after inflammation or injury to the heart. And so we want to be able to give them ACE inhibitors to help them reduce remodeling so that the heart can go back to its normal function. The only problem with ACE inhibitors, so um, they're blocking the angiotensin 1 and angiotensin 2 receptors, right? The only problem is the patient may develop a dry cough that can be really annoying and that can stop their adherence. So we want to let them know that this is a great medication to help the heart rate. It decreases the workload of the heart. But if they feel that the cough is starting and it's starting to bother them, there's always the means to change to another medication. And the last one is beta blockers. So beta blockers are the ones that end with OLOL, right? And they block epinephrine, which blocks the sympathetic system of the heart. It slows the heart rate and it decreases the workload. Okay. Let's see. So with beta blockers, we say that we don't give them to COPD or asthma patients because they can block the they take this medication so they don't take the medication because beta receptor block bronchoconstriction causing asthma attacks. So that's why we're careful when we are giving a person with a heart condition who also has asthma, beta blockers. Okay, so let's just recap, right? We know a person with high blood pressure, they have a disease that they really won't be able to notice unless they take their blood pressure. So we're constantly telling them that they have to monitor. We know that this disease is modifiable. Some of them are not, but some are. So we have to tell them to make sure that they know what is causing it. If it's secondary to something, they have to stop whatever it is, possibly change their lifestyle, make sure they stay on their medication. If it's losing weight or not eating salty foods, we have to tell them to do that. We also have to make sure they understand about hypertension crisis so that they know that organs can start to be damaged if they're not being adherent. And the organs that are affected the most are the eyes, the kidney, the brain, and the heart. So this is what I had to share with you for hypertension. I hope it was helpful. If you have any questions, feel free to reach out. Thank you.